So we want to talk about the endoscopic detection of squamous esophageal dysplasia or early squamous cell cancer of the esophagus. Now, lesion recognition, as we know, is pretty poorly taught for a lot of us, and particularly us in the Western world who see very little in terms of squamous dysplasia of the esophagus or even squamous cell cancer. It's something we're just not used to seeing and not used to picking up at all, which of course leads to poor prognosis for patients who have advanced disease. So if I could give someone one tip in regards to squamous dysplasia pickup, it'd be simply to make sure that every time you withdraw the scope from the esophagus, just switch on your image enhancement setting, be that narrowband, eye scan, BLI, and withdraw with image enhancement on slowly through the esophagus. Your squamous detection pickup will be exponentially higher by just doing that one simple thing. Just slowly withdrawing image enhancement on. We know that white light detection of squamous dysplasia is poor. It's notoriously difficult. You might see a little reddish patch. If you're lucky, you'll see some white coating. You maybe see some uneven surface, but it's really hard to pick up until it's more advanced disease. Now, when you switch on your image enhancement settings, what you'll then suddenly find, as you'll see by this video, is that things are previously invisible to the eye suddenly become actually quite obvious. And you'll see in this video that as we come slowly back through the esophagus with our image enhancement settings on, you'll see suddenly a little plaque appears. Now, this scope was done on someone for a completely different reason. It was for surveillance of his atrophic gastritis. But actually, by just as part of my routine practice with drawing the scope through the esophagus with my image enhancement on, suddenly this little plaque appeared that I'd missed on the way down. And you can see with image enhancement on, you see these sort of reddish brown plaques appear, and that is indicative of squamous dysplasia. And if you do that, if you withdraw and you see these little plaques, just biopsy them. Sometimes there might be nothing, that's fine, but I think your squamous dysplasia pickup will be hugely increased by just doing that simple thing. And you can see on this video actually is when we pause it, you can see that the image itself shows very clearly that there's a little plaque there, and actually you can start to see the differences in the IPCL pattern, which we'll come on to later. Now, this video also shows correct biopsy technique, where actually you can see we pull the biopsy forceps into the scope, move the scope head down onto the lesion, and then once you know you're in the right position, then you can push the biopsy forceps forward and close, okay, with a little bit of suction. Now, we know that previously we've used Lugol's chromoendoscopy for squamous cell pickup, squamous dysplasia pickup, and that's a great technique, and it's certainly something that's very easy to do. It's cheap, and essentially that involves a spraying Lugol's dye into the esophagus, and 1 or 2% Lugol's essentially, and what you'll see is that the esophagus goes entirely brown. That's because the glycogen within a normal squamous esophagus takes up the iodine, and in areas of dysplasia where there's less glycogen, you get a voiding. So essentially the esophagus goes entirely brown, and in areas of dysplasia, you'll see that there's pale bits that haven't taken up the Lugol's, and those bits certainly again need a biopsy, and you can see this in this diagram here. Now, Lugol's is great. Personally, actually, now that I'm more confident using image enhancement, I actually just use my image enhancement settings only. The problems with Lugol's is, people can have allergies. It can be painful for them with burning sensation or even spasm. And of course, the fear is always there's some sort of aspiration, or we spray it too high and you get pneumonitis or laryngeal edema. Actually, studies have shown that the use of narrowband or other image enhancement settings is effective as picking up squamous dysplasia as Lugol's in people who know what they're looking for. So that's why I just use image enhancement only. Where we often get confused, I think, is then when we start looking at studies, people start talking about magnification endoscopy and also this intrapapillary capillary loop pattern, this IPCL pattern. And really that's where it starts to get very technical and often loses us all in terms of our lesion detection. Now, IPCL pattern essentially is looking at whether there's squamous dysplasia, but also actually looking at the depth of invasion as to in terms of whether these lesions are amenable to endoscopic resection or not. Now, this is the Japanese Esophageal Society's simplified classification system, which actually is quite easy. Type A IPCLs are the normal IPCLs, or certainly those that don't show too much irregularity, and they are smooth, thin, small diameter vessels. Type B are always abnormal, and then they split that into 1, 2, and 3. One is where there's a loop formation, they are slightly wider caliber. That's early disease, so dysplasia or early cancers in the epithelial layer. That's certainly amenable to endoscopic resection. Type 2 is where the vessels get stretched, elongated, and even branching, and those ones are probably intramucosal or even early submucosal, and they're possibly amenable to endoscopic resection. That certainly should be discussed. And then the type 3 IPCL, type 3 B3 IPCLs are those that have dilated, big caliber loops, and they're very friable. They're not amenable to endoscopic resection. They are deep submucosally invading and not to be taken on by endoscopists. Now, IPCL pattern is worthwhile knowing, it's worthwhile learning, but as I say, going right back to the start, if we're trying to perform good, high quality diagnostic endoscopy for what we're doing day in, day out, actually, all you need to really know is switch on your image enhancement when you're withdrawing as a routine part of your practice. Make sure you withdraw slowly rather than being pleased that your scope's finished, and just come up, and any sort of red brownish plaques you see, biopsy them.